and he is a psychiatrist. He's been practicing down in Santa Ana, Orange County, for over 40 years. And he is, of course, he's in the medical field. He's a graduate from USC School of Medicine. And
UCLA.
Oh, UCLA. Oh, I'm very sorry. Oh, well, don't hang up on us.
Curtis, you're muted.
Oh.
Was I muted the whole time?
No.
Yeah.
Oh, did you hear the introduction?
Mm-hmm.
You did. You heard my mistake.
Yes.
Yes.
Oh, cool.
And then right after then.
Okay, that's humbling. Okay. He did his residency in LA at Cedars Sinai. His specialties are schizophrenia, depression, attention deficit disorder, attention deficit hyperactivity disorder, depressive disorder, insomnia, and sleep disorders. And so this, of course, covers much of what, we all share about when we have our Comey time. And if you have specific questions which you have not yet sent in, you can use the chat feature at the very bottom of your screen. If you just scroll your mouse down to the bottom, you'll see the mute button on the left side. And then about the fifth menu item to the right, there's a chat. So you just click chat, and I believe that you'll only have me as an option to send the questions to. So if you want to, you can send me questions during Dr. Okamoto's presentation. If you already sent it in, we should have it, and we'll be asking those questions first. Okay, so very happy to introduce Dr. Okamoto. I'm going to share my screen, which will include his PowerPoint slides. So welcome, Dr. Okamoto.
Thank you, Curtis. Thank you for inviting me, and honored to be part of the night and the support group and the speaker series. I'm not quite sure where you got your information from, but yeah, UCLA Medical School and Cedars Sinai is where I trained for the residency. I was going to be a psychoanalyst, actually. And then Prozac came out and our first daughter was born, and I didn't think I could afford psychoanalytic training. So I went to work for Dr. John Townsend and Henry Cloud after a couple of years, and did a lot of work with churches and the Christian congregations over a number of decades. Specialties are different things, but big part of it was mood disorders, and so depression, anxiety, and bipolar disorders. Not so much schizophrenia, but I've seen a number of patients who are schizophrenic, and ADHD is a big part of that now. Anxiety disorders. Did some clinical trials on mood disorders and some drug treatment programs, consulting with, and so a lot of different places I've done things with. So I'm one of the few Christian people left in Orange County. Everybody's moving to Tennessee and Washington State and Arizona and Texas, but so far we're sticking around. So haven't been called to another state like a lot of people. So hopefully tonight will be informative, but definitely we want to have a lot of time for questions. So a lot of my PowerPoint is to be kind of more of an outline of how I'm thinking about medicines. And for all of you folks who are dialing in, it's good you're trying to get information and going through the church for the information. There is such an explosion now with COVID talking about mental health, and this has been going on since the 70s with public health starting to realize that mental disorders mental illness is a big part of health globally, and depression has been within the top 3 disabling illnesses overall. So tonight we're going to talk about kind of mention mental disorders and how we categorize it, specific psychiatric medications and approaches to how psychiatrists use those, and also how, as a Christian, how does that impact your walk and your relationship with God and relationship with others? So it's a pretty big topic, and some churches are starting to bring mental health into their churches, but it's a hard fit. It's hard when you're trying to be a big church and appeal to regular folks. You have to depend on the spiritual development and spiritual maturity of a lot of folks to be able to incorporate people who have histories of addictions and mental disorders and depressions and anxieties, and to see that as part of who we are and who we minister to as being part of the body of Christ. I mean, it seems obvious because Christ ministered to those who are physically and mentally ill, and just to be aware of all the ways we are bound by this earth and have sin and imperfection in us, and how we need Christ for a restoration and reconciliation with God. So mental health has its place in stress and trials, like other stresses and trials. But I'm glad we're able to talk about this in particular here, because there's a lot of pain out there, and now we're getting so flooded with people looking for Prozac or mushrooms or ketamine or CBD, and everybody's getting their information from the internet and from the television and Facebook. So a big part of our job is to keep the structure of evidence-based medicine, make it healthy and true to medical science, as well as Christians, spiritual congruence with Bible and Christ. Okay, maybe we'll go to the next slide. So 6 out of the top 10 major causes of disability are mental health issues. Depression in 2018 was the most disabling illness, overtaking cardiovascular disease or heart disease. That goes up and down depending on the study in the year. 2008 to 2015, ER visits, children's hospital admissions for suicidal ideation or attempts more than doubled. And during the pandemic, kids have been extremely vulnerable. And if you've tried to take your child to mental health care during this pandemic, it's scary how long you have to wait and how you have to be in the line for good mental health care. It's very tough for kids. Next slide. So spiritual issues. I want to make clear too that spirituality and Christian mission, God is sovereign, and we are all imperfect on different levels for different reasons. We all have our genetics and our family inheritance of good and bad things. We all have a sin nature, and we all have needs to rely on God. So mental health, mental illness is not different. There is a struggle, there is a trial when we have these things, and it does have effects in a negative way, but the restoration of health on the mental health side also can be very positive and victorious through Christ and Christ's church. So loving God and loving others. I've had a lot of patients in a lot of mental pain or emotional pain who are solidly digging into the Christian walk and moving beyond to better spiritual growth. Next slide. This is kind of a smattering of how we see mental disorders. These are the boxes that we check. It's a lot of different ones, and it takes a lot of training to go through them. Part of it, we have a nature of trying to organize things that we don't understand in ourselves. And so some people go through the four humors, melancholic, sanguine, and all those. Some people have gotten into animals and things like the lions or bees or doves to categorize people. I think the latest, the horoscope and the year that you were born for us Asians, if you were a pig or you were a rooster or if you were a rabbit, all those are ways that we try to organize our unknowns. Latest, I think, is the Enneagram thing. But this is a way that we've kind of tried to put science to it and try to make healing a medical science. And it's complicated but limited. And so illness on the mental health side is not unending. There are different types, but not huge types, but everybody is different. It's not like different infections where you can treat with certain antibiotics. Everybody has a different spectrum and a different range and severity. And sometimes people will respond to medicines and sometimes they won't. So everybody is unique still, but we try. Next slide. So medications, there are, besides medications, there's psychotherapies that we're not talking about tonight, and there are neuromodulation interventions now that we didn't used to have as much. The one that you all know is electroconvulsive therapy or electroshock therapy. We're not talking about these tonight. You may have also heard about transcranial magnetic stimulation, or TMS, where a magnet pulsing is also a treatment for different types of anxieties and mood disorders. There's also psychosurgery, which is gaining in technique and knowledge that can be very helpful. And so there are a lot of new types of things that are coming up genetically as well. So we have a lot of new types of treatments. But tonight we're focusing on medications briefly as we try to give you a kind of a sketch of how psychiatrists group them and what we use for them. So how do we use medications? How are they helpful? How do they work? What is their effect on the brain? Are they addictive? Do they do harm? And spiritual issues about medications are all good questions. And we all think about them when we think about any medication. Let's say if your doctor prescribes you a pain medication, or even an antibiotic can actually make people hallucinate sometimes or change their moods. Hormones can change moods. Prednisone or steroids can change moods. So lots of regular medical type medications have the same kinds of questions that psychiatric medications do. It's just we don't really focus on that because we have a medical model that we try to sort of not think about those directly. But say if you have Alzheimer's or you've had a stroke condition, a lot of times we use similar medications in psychiatry. If you have epilepsy or seizures or pain syndrome, sometimes you'll be using psychiatric medicines as well, or some fibromyalgia, rheumatic inflammation diseases. Psychiatry is crossing over in a lot of areas. Next slide. I'm going to whip through these and there'll be a reference for us when we talk about the questions. Antidepressants, there's a number of categories. The ones that we hear a lot about now are called serotonin, selective serotonin reuptake inhibitors, SSRIs. Prozac, the Zoloft, the Lexapros, the Trintellix are the newer ones, Zoloft. So those are kind of what everybody knows. SNRIs, serotonin norepinephrine reuptake inhibitors, Effexor, Prestige, Cymbalta. You may have been on that or heard about them. NDRI, Wellbutrin is a norepinephrine and dopamine reuptake inhibitor. Older medicines that I prescribed that was kind of the ancient medicines now are MAO inhibitors. They're a little more side effects, but they were also helpful, and they still can be helpful, but the side effects are a lot stronger and riskier than the newer medicines. And tricyclics were the original antidepressants, Elavil, imipramine, and desipramine. Those are way ancient, from the 50s and 60s. So we've come a long way, and but we use these a lot for a lot of things now. Next slide. So this is, again, for anti-anxiety medicines. You may have heard benzodiazepines, and these are kind of like the bad guys lately: Valium, Xanax, Ativan, Klonopin. These are all GABA inhibitors, which makes them risky in terms of addictive potential. Some people will get addicted to them. You can get tolerant and have withdrawals that are severe if you, by happenstance or by body type, sometimes you will have trouble with these. And they also give memory problems. So we're really wanting to find some better medicines, but this group of medicines were actually so much safer and so much better than the previous medicines used for anxiety, which were the barbiturates. So when you think about phenobarbital or pentobarbital, these were very addictive and very dangerous, but anxiety sometimes was very severe, and these actually can be very life-saving. Non-benzodiazepines alternatives are not quite as helpful, but can be helpful. The antidepressants, SSRIs and SNRIs, Vistaril is an antihistamine, and Buspar or Buspirone is sometimes helpful, non-addictive, related to serotonin medicines, but doesn't work that well most of the time. Next slide.
Did I skip a slide, Doctor?
Yeah, but I didn't need it.
Okay.
Yeah. So, okay. Couple before that one. Okay. Antipsychotic medications are also, these medicines, the second generation or the atypical ones, these are used for schizophrenia. They're used for very severe agitation or hallucinations and severe anxiety sometimes, but a lot of times they're used as mood stabilizers because they have some serotonin reuptake inhibition, and they can act to even out moods in somebody who has cycling or up and down moods, bipolar moods, or unstable moods. And so a lot of people get these medicines if they have mood swings. The older medicines sometimes are still used for hallucinations and paranoia. Haldol, Thorazine, these are very old medicines, but they work on the chemical dopamine in the brain and can be very effective, even better sometimes than the newer medicines. Something that people don't know, if you get nauseated and you need compazine, another thing is called Reglan for stomach issues. These are very related to Thorazine, and sometimes you'll have side effects that are similar to antipsychotics if you take these and get one of these types of side effects, but we use them in other types of conditions on the medical side. Okay, 2 slides into mood stabilizers. So this is for a lot of treatments for depression are actually mood stabilizers besides antidepressants. So if your antidepressant doesn't work very well, sometimes we'll add these medicines that are mood stabilizers that are approved to treat just depression, even though they're treating very commonly manic depressive illness or bipolar disorder. So lithium was an old medicine that we used to help antidepressants work. But very typically we'll use now Abilify or Latuda. Sometimes we'll use things like Lamictal or Depakote. These are anti-epilepsy medicines that help stabilize nerves and nerve tracts, that actually help stabilize moods, because moods come from nerve tracts and nerve circuits with sometimes negative or errant or incorrect neural circuit behavior. And these medicines stabilize the circuits and the electrical patterns in the brain. Sometimes anti-anxiety medicines, Klonopin and Ativan, have been helpful for mood stabilizing too, but not quite as effective. So lots of different medicines can cross over different uses. So mood stabilizers have been used sometimes to help anxiety and sometimes depression, and they cross over a lot. So some people will get all the different medicines all together for a bipolar disorder or a depression with anxiety. Sometimes you'll have the same types of medicines that somebody with schizophrenia uses the same type of medicine. So it gets kind of confusing if you try to make it very specific, and if you try to think that it will all be simple. It's very unsimple, complicated. So two slides. So ADHD medications, stimulants, long-acting stimulants, non-stimulants. These down here, the Strattera, Quellbreathe, the Wellbutrin, Effexor, Nuvigil, Provigil are kind of second line. We had like Strattera and Intuitive, we were very hopeful they would do better, but there's for ADHD and ADD, stimulants are probably the most effective. The thing that's not great about the situation is that when you have ADHD or ADD, very often you have other conditions like an unstable mood or depression or anxiety, whereas sometimes the stimulants make things worse. And very often with ADHD or ADD, it comes along with substance abuse issues. And so if you have a substance abuse issue of being hooked on meth or stimulants, then you sort of can't use these because that will trigger the addiction again. So you're kind of more stuck with second line medicines. But very often if you have an ADHD problem and you have other addictions, like it's marijuana or it's alcohol, sometimes you can use stimulants, and you can actually help make the sobriety and recovery better if somebody has better concentration, focus, and less distractibility. So sometimes people are afraid of using ADHD medicines when there is some kind of addiction background, but actually sometimes it helps people to work their programs better, and it can help things like anxiety and mood quite a bit if the ADHD is treated well. We sometimes think of ADHD or ADD as not as harsh as depression or anxiety problems or psychotic problems, but sometimes treating ADHD is very miraculous. It's just dramatically helpful for some people, and their lives are so changed by being able to focus and concentrate and use their forebrains and their concentration abilities in an adult manner. So it really can be transformative. Okay. We have sleep medicines too as part of it. So we can look at that slide very briefly. Sleep is very important to because it's a lot of times disrupted in a lot of these conditions, anxiety, depression, mood problems, schizophrenia, ADD. If you have good sleep, a lot of times it helps stabilize your mood and keep your mood stable. It also helps with anxiety and depression. So sleep, good sleep does a lot for mental health. We try to avoid chronic medicines, but sometimes we have to use them. And sleep is a whole hour talk by itself, but I didn't want to miss that and leave that off. But as soon as we can, I wanted to get to the question and answers because those are more important, I think, than PowerPoints. So anybody have questions about the slides, or I don't know, Curtis, if you have specific things. I wanted to keep it as minimal to the didactic stuff as possible, because these are all things that you'll have access to the slides. You can look them up, and I mean, they're all accessible online. NAMI, National Alliance on Mental Illness, does a great job with making some of this stuff very accessible. But questions, I think, are much more important because you don't get that on websites. So anything that I can answer generally, I can't answer specific case questions, but I can talk about general approaches and what we do as psychiatrists and what we try to do in certain types of treatments. So